So when we're doing the facial nerve monitoring, so this is a video, we can see the surgeon is holding a probe on the right side, and we are monitoring all the nerves at the cranial, of all the branches of the facial nerve. Facial nerve branches are very hard to identify in the parotid gland because this is a very tough tissue and the branches are spreading out. So stimulating on the surface and we can get the responses so the surgeon is holding this bipolar probe and stimulating, and you can see some contraction in the muscles at the same time. Lateral spread response is another technique which is used for the facial nerve, microvascular decompression of the facial nerve. So when the patient has hemifacial spasm, or which is a twitching on the face, it could be very painful. So the surgeon, and if they don't respond to the conservative treatment, pain medication or Botox injection, the surgical treatment is to do microvascular decompression, which is the placement of the Teflon or something between the blood vessel on the facial nerve, because each pulse is the blood vessels, mostly ICA, is touching the facial nerve, and with each pulsation it's rubbing the nerve and called demyelination of the nerve. So in order and that get demyelinated and get painful over the period of time. So all we have to do for microvascular decompression, we elevate the blood vessel and put a Teflon or something, a gauze between the two so it doesn't rub on that. The clinical testing for this one is to do a lateral spread response. A lateral spread response is done by placing the mandibular branch. If you stimulate the mandibular branch, supplying the oculi, you should get response only from mentalis or maybe oris. But if you get a delayed response in another muscle, for example, this picture on the left side, the left top, we are stimulating the maxillary branch, the zygomatic branch, and getting response from the oculi, and also a late response from the mentalis muscle. So if that means the current is spreading to the other side, which is not, and that is because the orthodromic, the muscle motor response go to the muscles, antidromic motor go toward the brainstem, and then it bounces back from the demyelinated due to 3-4 different reasons, and then it come back and activate the muscle, and then you can see the response spreading out to the other muscles, which are not supplied by those specific branch, and that's one of the reasons the responses are delayed. When we do the microvascular decompression, if it is successful decompression, that response disappears. So if that response disappears due to stimulation, we know that MVD is successful. So these are one of the few scenarios where the disappearance of the response means that it's a good. Most of the time, the disappearance of response means a bad scenario. But here, because the response is abnormal, so we want the response to disappear. We have to make sure the patient has no muscle relaxation, because if you have muscle paralyzed, you cannot monitor lateral spread response. We also want to make sure patient have no Botox injection in the last 6 months, because Botox causes paralysis of the muscles, and if done in less than 3 months, we will not be able to do the lateral spread response in the correct way. So damage to the facial nerve will result in loss of the forehead and brow movement, inability to close the eyes and it results in drooping of the eye, the loss of nasolabial fold and drooping of the lower lip. If they ask the patient to smile, so patient will be able to smile, but the face will be tilted to the normal side, because the paralyzed side doesn't contract, so there's compensation, so the face is tilted to the normal side. If you ask the patient to close the eye, patient will not be able to close the eye because the eyelids cannot close. But the eyes roll back. So normally we are called Bell's phenomena. When you close the eye rolls back, but you cannot see that because the eyes are closed. But with the facial nerve is paralyzed, and you ask the person to close the eye, so they try to close the eye, but the eyelid doesn't close, but the eyeballs move up, and that is known as facial Bell's palsy. So Bell's phenomena and Bell's palsy are two different things, but related to each other. So this is one of the paper we published about monitoring the fourth ventricle, because fourth ventricle has the nuclei for all, for a lot of nuclei, the cranial nerves, and then we can stimulate the floor, and we can record the activity, and we can tell the surgeon that where is the nuclei of the cranial nerve. and we can do by Corticobulbar MEP or direct brainstem mapping. The eighth cranial nerve is the second next one, which is the response for balance and hearing, also known as brainstem auditory evoked response or brainstem auditory evoked potential. So there are three ways to monitor that: either monitoring by auditory evoked response, brainstem auditory response (BAER), or monitoring directly from the nerve, which is known as auditory nerve action potential, or recorded from the cochlea, which is electrocochliogram. Electrocochliogram is the peripheral response, just like R's point of public fossa, and tell about the integrity of the stimulation and the cochlea. If the cochlea is damaged or the ischemic, then we don't see any responses. But if you're not monitoring electrocochliogram and we have no responses, we don't know it's because of damage to the cochlea or loss of stimulation. So having those three can help the surgeon. So the purpose of doing the vestibular cochlear nerve monitoring is to monitor the three main functions: to protect the cochlea, protection of the cranial nerve 8, and also the protection of the brainstem. Because it is going to the brainstem, so if there's a change, we know the brainstem is getting affected. There are 7 peaks which are produced along the pathway and the brainstem auditory evoked response. Wave number 1 is postsynaptic distal cochlear nerve. So when the cochlear nerves start from the cochlea, the first response produces wave 1 at this point. When the nerve travels to the auditory canal next to the facial nerve and enter the CSF near the brainstem, so there's a change in medium, and that's created wave 2. So proximal auditory nerve create the wave 2. The third wave 3 is produced in the superior oblique complex or cochlear nucleus. Wave 4 is produced in the lateral lemniscus and the pons. So 4, 5, and 6 and 7 are produced on the opposite side. Wave 5 is inferior colliculus in the midbrain. Wave 6 is mediate geniculate in the thalamus, and wave 7 is the thalamocortical radiation. What we want to monitor the common peaks from 1 to 5, 1, 2, 3, 4, 5. We want to monitor the obligate peaks, which are wave 1, wave 3, and wave 5. So those obligate peaks should be monitored in each case. Then the largest peak is wave 5, and we also amplitude of the wave 5 or the ratio of wave 5 to wave 1. And we also want to monitor the interpeak latency, which is important, of 1 to 3 or 3 to 5 and 1 to 5. So if there's a delay in 1 to 3, that means the problem is a nerve outside the brainstem. If the delay is between 3 and 5, it means the problem is a brainstem or it's not a nerve problem. And both will affect wave 1 to 5 latency because both are combination. In combination, they both create wave 5. So this is data from recording from brainstem auditory response at the bottom, and then electrocochliogram and auditory nerve action potential. The auditory nerve action potential is done by placing the nerve, a cotton wick electrode or Kuva electrode, which is a snap-on electrode, on directly on the nerve with the exposed brain, and you can stimulate and you can record. The latency of electrocochliogram is same as wave 1 because electrocochliogram is produced in cochlea and wave 1 is produced also in the distal auditory nerve. So it's almost the same, but the electrocochliogram is not wave 1, it is electrocochliogram. The latency of the auditory nerve action potential is same as wave 2 because it is recorded from the proximal nerve, but it is not wave 2, it is the auditory nerve action potential. So the placement of the electrode, you can place the electrode and then the needle electrode should be placed anterior to tragus, not on the earlobe, because then you are not recording anything. So try to place on the earlobe. The ear inserts are placed and then covered by the bone wax and then by 4x4 gauze and tegaderm. Vertigo auditory nerve action potential can also be used for monitoring the treatment of vertigo, in which if the patient doesn't respond to any other treatment, we can go and do the vestibular neurectomy. So if you stimulate the auditory nerve and you put a cotton wick electrode on or a probe on the vestibular part, you're not going to get a response. Place the ocular part, we get a response. So we see where they split, and then we can the vestibular part we are going to cut. Cranial nerve number 9 is the glossopharyngeal nerve. It is responsible for taste of posterior 1/3 and swallowing. It is monitored by placing the electrode at stylopharyngeus muscle or soft palate, posterior 1/3 of the soft palate. We can do Corticobulbar MEP and spontaneous and triggering EMG for the cranial nerve number 9. Cranial 10 is the vagus nerve, which is the longest nerve in the body. Vagus means wandering, and so it's wandering. And it is also monitored during the anterior cervical discectomy because ACDF can also cause retraction of the recurrent laryngeal nerve and damage to the vagus nerve. Well, recurrent laryngeal nerve is a branch, and superior laryngeal nerve are the branches of the vagus nerve. So, and also the carotid endarterectomy. So when they are retracting on the carotid artery, carotid sheath, it can also cause the stretching of the vagus nerve. So the different hormones secreted by the thyroid are can create the lack of secretion called hypothyroidism, and if it's overstimulation called hyperthyroidism. And these are these are symptoms of hyperthyroidism: is anxiety, irritability, nervousness, sweating, hand trembling, hair loss, or missed or light menstrual periods. For hypothyroidism, troubleshooting, tiredness, fatigue, difficulty concentration, dry skin or hair, depression, sensitivity to cold, frequent and heavy period, and joint and muscle pain. So those are the symptoms of the patient as a hypothyroidism. So cranial 10 in vagus means wandering, and it's the longest nerve start in the brainstem, exit to the jugular foramen, next to the cranial nerve 9 and jugular vein, and it travels in the neck and chest and abdomen and pelvis. It reaches the pelvis to the gonads. The function, there are three main functions of the vagus nerve. One is power source, the second vibratory source, and second is resonator. Power source means the breath, power is the sound, vibratory source is the vocal fold cause vibration, and it causes the complex sound, more smoothness of the sound, and resonators cause richness of the sound. So if superior laryngeal is damaged, it may cause effect on resonator and vibration, but not power, and vice versa. So thyroidectomy is a procedure to remove the thyroid gland, and the vagus nerve is traveling to that. So it's always recommended to monitor, and especially bilaterally. We can use the endotracheal tube by placing, and then we can monitor endotracheal tube, and then we monitor the EMG from the superior laryngeal nerve. Here we can see unilateral one-sided portal paralysis on the left side, and one side of the vocal cord is paralyzed. Patient is not moving. The complication due to paralysis can be voice changes, aspiration, airway restriction, and need tracheostomy for this patient. Patient cannot breathe. So vagus nerve have two major branches which we monitor: recurrent laryngeal nerve and superior laryngeal nerve. Recurrent laryngeal nerve comes and wrap around the arch of aorta on the right side, and it travels longer on the left side, and it makes it loops back from the arch of aorta, and then it supplies the vocal cord. And on the right side, it goes under the subclavian artery and then come back. So superior laryngeal nerve is supplied by cricothyroid muscle, and recurrent laryngeal is supplied by placing the electrode on vocal cords. Superior laryngeal can be done by placing the electrode on cricothyroid muscle, and that has to be done sterilely because that muscle is behind the thyroid and we cannot reach it. So we have to give the electrode to the surgeon sterilely and not opening on the field. So we are not opening outside the field, so you have to open on the field or give to the circulator to open the field, and surgeon place the electrode after removing some part of the thyroid gland before resection. So they place that and then unplug and then go to the other side. There are different ways to record these nerves, vagus nerves. So we can have endotracheal tube, and the endotracheal tube can come with bipolar recording, like two on each side, electrode stamp on the endotracheal tube up just above the bulb. They can come in one channel, like one on left and one side, so they're not sensitive, or they can come in the endomet to make this electrode, which is wrapped around any size of endotracheal tube, and you can use the pediatric and adult side. The one with the tube, they come only on three sizes: 6.5, 7.5, and 8.5 millimeter. So they cannot be applied on the infants or other people with other size. So for thyroidectomy means we can see we are stimulating and the spontaneous EMG is okay. And when you start stimulating, we can see the response about 2 milliampere, negative response going downward, upward. So the response is coming at the same location. Cranial 11 is the spinal accessory nerve, which supply the trapezius muscle, and it has cervical root from C1 to C3, and they go up to foramen magnum, and then join with the cranial part, and they come from the jugular foramen and supply the some part of the sternocleidomastoid side and mostly trapezius muscle. Hypoglossal, the last 12 grain of hypoglossal nerve, which supply leaves the cranium from the hypoglossal canal, and then it travels to supply the muscles of the tongue, and is the only motor nerve. Can be monitored by Corticobulbar MEP or EMG, spontaneous EMG. So when you are stimulating, we have to make sure we are following all the rules of the guidelines. The electrode impedance should be less than 5 kilo ohms for the pair, and single 2500. Ground electrode should be placed between stimulation and the recording to decrease the artifact. Monophasic rectangle pulse is delivered, and the typical stimulus parameters includes pulse rate of 100 microsecond or 200 microsecond, and the rep rate of 3 to 5 hertz. So when we are stimulating, we can get a current shunting or current jumping. Current shunting means that there's fluid touching your probe. So the current, instead of going to the structure you're stimulating, it is picked up by the probe, and it travels to the fluid to the probe. So because the current always takes the path of least resistance, so the fluid, CSF, blood, they have least resistance, so current will be shunted toward the fluid. On the other hand, on the right side, current jumping is like when you're stimulating one branch but activating the other. Here we are stimulating the acoustic nerve, vestibular nerve, but or the auditory nerve, but the facial nerve is also there. So the current is very high, and it's causing activation of the facial nerve. So that's why it's about to titrate and stimulate at the lower threshold, not at the maximum, because when you go very high, you can activate the other nerves and look like a true response. Stimulation can be done by monopolar or bipolar probe. The monopolar probe you can use as a flash bipolar probe with the concentric, or we can do on the right side at the lower bottom, we can see continuous electrode, which is placed. You can just snap on the nerve and continuously monitor the nerve throughout the surgical procedure. The different factors that will affect our responses, and that include tumors, diabetes, MS, vasculitis, ischemia, or SLE, and syphilis, and other drugs. So pituitary tumor, if the patient has a pituitary tumor, it is attached to the pituitary stalk, which is attached to the optic chiasm. So when you try to pull it out, it causes pressure on the optic nerve and cause optic nerve changes, so the surgery has to stop. So make sure we are either if they're doing optic nerve stimulation in these cases, and what is the reason of the change. Acoustic neuroma are the tumors of the acoustic nerve or auditory nerve, and ipsilateral facial nerve is at risk, and hearing deficit on the right side. So because the tumor is on the outer part of the auditory nerve, which already cross the brainstem. So before the stem, they are on the ipsilateral side, and after brainstem, they are in its contralateral. So they supply the ipsilateral side. So this is two patients from pediatric patient which we published about fourth ventricle tumor. The tumor is right in the fourth ventricle. It's hard to identify the fourth ventricle. Again, what are the outcome? These patient with the CPA tumors, because their injection of cerebellum and pons, so called CPA tumors. If you place all the electrode 3, 4, 6, 5, 6, 9, 10, and 11, and 12, so this is how the patient will look like. So you have to make sure the patient is secure. And trainer 4 is very important for these ones because we are monitoring EMG and MEP specifically. So patients should have trainer 4 throughout the surgical procedure, except for the exposure part. This is the EMG from cranial nerve, and we can see the EMG firing from the masseter, oculocranial and sternomastoid, and this is because they switched the machine to another machine, and they were recording this for these signals. Trigger EMG from our paper, so we can see the probe fourth ventricle on the right side image. The surgeon stimulating, we're getting responses at 0.8 milliampere. So at 0.8 milliampere, we're getting responses from oculi and oris, both of them, and some of them. So we have to differentiate in them. Corticobulbar MEP has a risk of, corticobulbar MEP is done by stimulating half of the brain. So if the surgery is on the right side, then we stimulate the left brain, and the left side is stimulate the right side. So instead of stimulating from C3, C4, or C1, C2, we stimulate C3, CZ, or C3, C4, C4, CZ. It's important to remember that CZ should always be negative, cathode, and C4 and C3 should always be positive. You can also use M1 CZ and M2 CZ. So C3, C4 should always be positive, positive, because the activation of the brain is under the anode. In this picture, we can see corticobulbar is responsible from right oris, right nervocalis, trapezius, and left and tongue muscle. But when we are stimulating the scap, the current also spread over the skin and cause direct activation of the muscles. So that's called peripheral response. Or on the red line, you can see that's a corticobulbar pathway where the upper motor neurons is activated and the signal comes down to the brainstem, and it makes a synapses in cranial nuclei, and then lower motor neuron comes and supply the muscle. The motor fiber, they originate from the cortex, and 1/3 originate from the premotor gyrus, 1/3 from the premotor gyrus, 1 from precentral gyrus. So precentral gyrus, M1 and prime motor gyrus are the same. So 1/3 originate from there. 1/3 from premotor gyrus, which is anterior to the motor gyrus, and 1/3 originate from somatosensory. When all they combine, the corticobulbar fibers, they leave the brain and they supply the nuclei of the brainstem, and the corticospinal tract, they cross over 80% and supply the upper and lower limbs, and 20% stay on the same side, and they cross at every segment level C1, C2, and they supply the muscle of the trunk. But if you're not doing double train, so it's very important. The research has shown that we should be stimulated with double train, with a train and then single pulse. And if you get a response after single pulse, that means or both single pulse. If you're getting only after single pulse, that means that there's a current spread and you're activating the direct muscle. If you're getting with current single pulse and train, then we are not sure the response is either peripheral response or it could be a mixed response. But if you have response only by train and not the single pulse, that means it's a pure corticobulbar response. Why? Because the corticobulbar pathway cannot be activated under anesthesia with a single pulse, but the activation of the current spread is single pulse is fine. So here, we need to add like a single pulse. So in this picture, we have single pulse and then 30 millisecond delay, and then 3 train, 5 train on the first trace on the top. The ideal recommendation is to do 3 train and then 90 millisecond stimulation, inter-stimulation, inter-train interval, and then 1 pulse. But we can see the first few traces. We can see the first trace is 5 pulses, and we have response by single pulse, and then after 5 pulses. So change the pulses from 5 to 3, still getting response from both of them. There's no change by pulses, and then start decreasing the current, and then you come down, and at the lower level you can see we have the single pulse response getting smaller and then disappear, and this response in the oris muscle get a little bit smaller, but the mentalis is very stable. So for the lower 4-5 for the stimulation, we are more confident that these are pure corticobulbar MEP responses, where the upper responses, first traces, they are response from the single and train. So those are not reliable responses, so we should not be doing that. These are the recording parameter, typical recording parameter for spontaneous and trigger EMG. If the patient has changes or damage to the optic nerve, it will result in vision loss. If the cranial 3 is damaged, patient will which is oculomotor nerve, so patient will have downward and outward movement loss. Patient will have lateral rectus palsy, cranial 6 abduction loss. Patient will have lateral eye movement loss, so the eye will be tilted toward the mid side. The patient has facial nerve, and so we ask the patient to close the eye. On this picture, patient right eye is closed and the face is going toward the right side. That means the left side is paralyzed. So patient cannot close the eye, Bell's palsy, and the facial muscle of the lips are paralyzed on the left side, so they don't contract on this patient. Hearing damage to the 8th cranial nerve, which will result in hearing loss or hearing deficit. Hypoglossal nerve will result in muscle wasting of the cranial. So The principle of monitoring these cases, the important part is to make sure we are selecting the appropriate modalities for each procedure. So identifying what structures are at risk and which cranial nerves are at risk, different stimulation, making sure we are using the correct recording electrodes, we are using the correct stimulation electrode. So we can use the stimulation electrode monopolar or bipolar, or for recording we're using either regular subdermal needle, longer subdermal needle, which are recommended for the oculomotor eye muscles, or using for facial nerve or the cranial nerve, the fine needle hook wire electrode, or if it is auditory nerve, we use the Corticobulbar electrode for electrocardiogram, or we can use gold foil electrodes, or we can for the auditory nerve action potential, we place the electrode on directly on the auditory nerve, so you can use gold foil soaked in isoline, or we can use Kuva electrode. So all these visual electrode potential, we need the goggles for stimulation, and then we use optic. If we are doing the retinal responsive ERG, we can place the contact with gel, so that it doesn't on the retina, or you can place the two electrode next to the medial and lateral canthus. So in the left eye and right eye, needle outside the eye, the angle of the eye, so you put one hair on one hair, and reference to each other, they will also give you a good ERG responsive. So, and for the cranial, it's always good to stimulate proximally and distally, and we see the changes in the amplitude or latency between the two. And if you stimulate proximal to the surgical side and get a response, that means the nerve is okay and there's no damage to the nerve. If you get a response, the distal to the surgical side and get a response and get stimulated the proximal, and we don't get a response, that means the nerve is being compromised. So active versus passive monitoring is the term we use. Active monitoring is where we are continuously monitoring and we are not giving any break, and which is very important for this all type of monitoring, because we don't want to sit and respond to a change or respond to an action. So if you stimulate, if there's an EMG activity and you're doing MEP to make sure everything's okay, or you're doing trigger EMG, everything is sure, that's more passive monitoring. So you are not continuously monitoring. The surgeon is stimulating every 5 minutes, 10 minutes, or 20 minutes, and there's no gap between the. So there should be continuously active monitoring of all the nerves, or the spinal cord, or brainstem and brain, and on top of that, we can do mapping, which is passive monitoring, not continuous one. Selection of the appropriate equipment is also critical, depending on how many channels data. If you have a big setup, then you need a 32-channel machine, otherwise 16-channel will be helpful. Selection of anesthesia is very important. Make the patient has total intravenous anesthesia, they're not using inhalation agent. If you're using visual evoked potential, you have to have very low anesthesia, 0.3 or less MAC, because it's going to affect that, and it's very hard to do that. So, and making sure there's no muscle relaxation, making sure keep doing train of 4 during the surgical procedure. Even you have good train of 4, you still do every 15 minutes and record on other inhalation agent. Assigning a trained neurophysiologist or technologist is very, very important for a good outcome. The studies have showed that if you compare between the two teams, the team which has more experience, even both are experienced, even with the more experience, have less than 50% less post-op deficit than the team with the less experience. So without monitoring and with monitoring, there's a significant change, and with monitoring, again, there's a change between the less trained and more trained teams. So in conclusion, there's a significant improvement in the post-operative neurological outcome when we are using a multi-modality IOM. So we cannot pick only one and say that everything will be fine, because there are different structures. It is a sensory motor, more than one cranial nerve. So all the cranial nerves, so we do a multi-modality, including a sensory evoked potential, EEG, and motor evoked potential, and making sure, we can do the hearing preservation and facial nerve preservation in all these cases. So integral to the ION success during cranial surgery is the experience of surgical physiologist and the team which is involved, and the communication is also very important between the IONM team, the surgeon, and anesthesia, and also the reading physician online, or in the OR. The intraoperative neuromonitoring has decreased complication of neuralgia related to microvascular decompression surgery, and it has improved the postoperative outcome in these surgical procedures. So the takeaway is to understand the anatomy and physiology of all the cranial nerves. So it is important to understand and study in more detail uh, the anatomy and physiology of each cranial nerve. So within a short lecture, it's very difficult to explain, go to that, because every single cranial nerve need a separate lecture in itself. So, but to understand the anatomy and physiology of the functional and the nerve supplying and also the blood supply around those nerves is very important. Memorize and understand the recording and stimulation parameters, because when you're in the operating room, if you have the data on your recording on the desktop, that's good, but sometimes you have to do everything very quickly, so you have to make sure you are stimulating in the appropriate parameter and you are not causing any damage. For example, if you're stimulating any cranial nerve intracranially, the maximum stimulation for direct nerve stimulation is 1 milliampere. So we should not be stimulating more than 1 milliampere, but for direct cranial stimulation is going to cause damage. For indirect cranial stimulation, you can go up to 2 milliamperes. The nerve is behind the bone or behind the tumor, inside the tumor, you can go up to 2 milliampere. But for direct nerve stimulation, 1 milliampere is maximum. The threshold is very important, so we have to make sure that we are stimulation. If the threshold increases before surgery and after surgery, that means the nerve has been compromised. So, for example, for facial nerve, the baseline, you get response at 0.2 milliampere, but at the surgery, you're getting same response at 0.8, 0.9. That means the patient will have some kind of deficit. So the action we should take in the operating room is to understand what's happening, to understand the surgical procedure, to understand the structure which are at risk, to understand the anesthesia involved, the accurate anesthesia, or what are the changes in anesthesia that can occur, observe them closely, and get training, and then perform yourself. Thank you.